What if one of the pills sitting in your medicine cabinet right now is quietly increasing your risk of a heart attack or stroke? Not a pill you bought carelessly, not something you took without a prescription, a medication your own doctor gave you, perhaps years ago, perhaps even decades ago, for a very real and legitimate reason. What if that pill, which once helped you, is now doing something inside your aging body that neither you nor your doctor has stopped to fully reconsider? This is not a question meant to frighten you. It is a question meant to wake something up, a healthy curiosity, a willingness to look more carefully at what you are putting into your body every single day. Because here is what most people over 60 are never told. The medications that were appropriate and safe for your body at 45 or 50 do not automatically remain appropriate and safe at 65 or 75. Your body has changed. Your blood vessels have changed. Your kidneys, your liver, your heart, all of them process medication differently now than they did 20 years ago. And yet, for millions of older adults, prescription bottles are refilled month after month without anyone asking whether the original calculation still holds. In this video, you are going to discover 5 specific categories of medication that experts and geriatric physicians are increasingly concerned about in adults over 60. You will learn why they become more dangerous with age, what warning signs to watch for, and what conversations to have with your doctor. Stay until the end, because pill number 1 surprises almost everyone. If you want simple health tips that help you stay independent and healthy after 60, subscribe and turn on notifications. It only takes 2 seconds. To understand why certain medications become more risky after 60, you need to understand something that most people never think about. Your body is not a static system. It changes constantly, and those changes accelerate as you move through your 60s, 70s, and beyond, in ways that profoundly affect how every medication you swallow behaves inside you. Think of your body like a car that has been running for decades. The engine still works, but it runs a little differently than it did when it was new. It takes longer to warm up. It processes fuel less efficiently. Certain parts that used to function with very little maintenance now need more careful attention. A grade of fuel that worked perfectly well 10 years ago might not be the ideal choice for the engine as it is today. Your kidneys are one of the most critical factors here. These 2 organs are responsible for filtering medications out of your bloodstream and excreting them from your body. After the age of 60, kidney function declines gradually in almost everyone, even in people who are otherwise healthy and have no kidney disease. This means that medications which would once have been cleared from your system in hours may now linger significantly longer, accumulating to higher levels than intended and producing stronger effects than your doctor calculated when they first wrote the prescription. Your liver, which breaks down many medications before they even reach the bloodstream, also becomes less efficient with age. Liver blood flow reduces. Enzyme activity slows. The result is that some medications are processed more slowly, staying active in the body longer than they should. Then there is the question of your blood vessels themselves. As we age, blood vessels naturally become stiffer and less flexible. The inner walls of arteries accumulate small changes over decades. Blood pressure regulation becomes less nimble. And in this context, certain medications that affect blood pressure, fluid balance, heart rhythm, or circulation can produce effects that are far more pronounced and far more dangerous than they would have been in a younger, more adaptable cardiovascular system. The cumulative result of all these changes is a body that is more sensitive to medication, slower to clear it, and less able to compensate when something goes wrong. A side effect that was mild and manageable at 50 may become a serious health event at 70. A medication that carried a small acceptable risk at one stage of life may carry a much larger, less acceptable risk at another. And the tragedy is that this recalculation almost never happens automatically. It requires someone to stop, review, and ask the question. Today, that someone is you. The fifth pill on our list is something that millions of adults take every single day without a second thought: non-steroidal anti-inflammatory drugs, more commonly known as NSAIDs. You probably know them by their brand names: ibuprofen, naproxen, diclofenac. These are medications that are sold both over the counter and by prescription, and they are taken for entirely understandable reasons: arthritis pain, joint inflammation, back pain, the aches and stiffness that become increasingly common with age. Here is what most people taking them do not know. NSAIDs work by blocking certain chemical signals in the body that cause inflammation and pain. But those same chemical signals also play an important role in protecting the lining of the stomach, regulating fluid balance in the kidneys, and maintaining the flexibility of blood vessels. When you block them, you relieve pain, but you also remove some of the body's natural cardiovascular protection. In older adults, regular NSAID use, even at doses that seem modest, has been associated with increased risk of fluid retention, elevated blood pressure, and in those with existing heart disease or kidney issues, a meaningfully higher risk of heart attack and stroke. The kidneys, already filtering more slowly in an older body, can be put under significant stress. Blood pressure that was well controlled on medication can become harder to manage. And because arthritis pain is chronic, many seniors take these medications not for a week or two, but for months or years continuously. Warning signs to watch for include swelling in the ankles or feet, a noticeable increase in blood pressure readings, reduced urine output, or a feeling of unusual shortness of breath. If you are over 60, have any history of heart disease, kidney concerns, or high blood pressure, and you are taking an NSAID regularly, this is one of the most important conversations you can have with your doctor, particularly about whether there are safer alternatives for managing your pain. Let me tell you about Francis Okonkwo. Francis is 71 years old, a retired district nurse from Birmingham, England, with a warm personality and the kind of practical, no-nonsense approach to life that you might expect from someone who spent decades caring for others. She had type 2 diabetes, mild hypertension managed with medication, and arthritis in both knees that had been limiting her walking for several years. For those knees, Francis had been taking prescription diclofenac, a potent NSAID, fairly regularly for about 3 years. It helped. Without it, the pain made even short walks uncomfortable, and Francis was determined to stay active and independent. She did not consider the diclofenac particularly significant. It was just something she took for her knees. What Francis had been noticing, and attributing entirely to her diabetes and age, was a gradual worsening of her energy levels. She was also finding that her blood pressure, which had been stable for years on the same medication, was becoming harder to control. Her readings at home were consistently higher than they had been. Her ankles were swelling by the end of the day. She felt heavy and slow in a way she had not felt 2 years earlier. When her GP conducted a thorough medication review and identified the regular diclofenac use, the picture came together. The NSAID was contributing to fluid retention, which was elevating her blood pressure and placing additional strain on her heart and kidneys. Under careful medical supervision, Francis was transitioned to a combination of physiotherapy, topical anti-inflammatory gel applied directly to the knee rather than taken orally, and a gentle exercise program designed for arthritic joints. Her systolic blood pressure, which had been running around 158, dropped to 138 within 2 months. The ankle swelling resolved. Her energy improved significantly. Francis told her doctor something that stayed with him. "I spent 3 years thinking my body was giving up on me. It turned out I was giving it something that was quietly working against it." The fourth pill deserves careful attention, particularly for those of you who have been managing acid reflux, heartburn, or stomach ulcers for years. Proton pump inhibitors, commonly known as PPIs and sold under names like omeprazole, lansoprazole, and pantoprazole, are among the most widely prescribed medications in the world, and they are genuinely effective at reducing stomach acid and preventing the burning discomfort of acid reflux. But here is what the research is increasingly showing about long-term PPI use, particularly in older adults. These medications, when taken for extended periods, months or years, rather than the few weeks they were originally designed for, have been associated in several large studies with an increased risk of magnesium deficiency, reduced absorption of certain vitamins including B12, and emerging evidence of potential effects on kidney function over time. There is also research suggesting that long-term PPI use may be associated with a modestly increased risk of cardiovascular events in certain populations, though this relationship is still being actively studied and is not yet fully understood. What is clear is that many seniors who started a PPI for a short-term reason have simply continued taking it indefinitely, sometimes without any ongoing clinical justification. If you have been on a PPI for more than 3 to 6 months, it is worth asking your doctor whether you still need it at the same dose, whether a trial reduction might be appropriate, and whether lifestyle modifications might reduce your reliance on it. The third pill is one that surprises many people because it sits in a category most seniors associate with safety rather than risk. Certain antihistamines, specifically older generation antihistamines like diphenhydramine, which is found in many over-the-counter sleep aids and allergy medications, carry cardiovascular and cognitive risks in older adults that are significantly underappreciated. Diphenhydramine is what pharmacists call anticholinergic. It blocks certain nerve signals in the body, which is how it reduces allergy symptoms and promotes drowsiness. But anticholinergic effects in an older body extend well beyond sedation. They can cause increased heart rate, urinary retention, constipation, and in some cases, confusion and short-term memory difficulties. There is growing research suggesting that high cumulative anticholinergic burden, meaning the total amount of these types of medications taken over time, may be associated with an increased risk of cognitive decline in older adults. From a cardiovascular perspective, the acceleration of heart rate that diphenhydramine produces can be problematic for seniors with existing heart conditions, high blood pressure, or a history of arrhythmia, irregular heartbeat. If you are taking an over-the-counter sleep aid regularly, check the ingredients. If diphenhydramine appears on the label, this is a conversation worth having with your doctor, particularly if you have any heart-related history. There is a myth that runs quietly through so many conversations about medication, and it needs to be addressed directly. The myth goes like this: if my doctor prescribed it, it must be safe. And if I've been taking it for years without any obvious problems, then it's working and there's nothing to worry about. This belief is understandable. It is rooted in trust, which is a good thing, but it misses something important about how medicine works and how bodies change. Medical knowledge evolves. What was considered best practice for a 65-year-old in 2005 may look quite different in the light of research published in 2020 or 2024. Guidelines issued by organizations like the American Geriatric Society, the European Society of Cardiology, and the British Geriatric Society are updated regularly as new evidence emerges, and those updates sometimes change the calculus around medications that were previously considered low risk. Your body also evolves. The medication that was appropriate for your physiology at 58 may not be appropriate for your physiology at 72, even if nothing has gone dramatically wrong in the interim. Kidney function declines gradually. Cardiovascular flexibility changes. Brain sensitivity to certain compounds increases. None of these changes announce themselves with a dramatic symptom. They accumulate quietly, and so do medication risks. A study published in JAMA Internal Medicine found that a significant proportion of older adults taking multiple medications were on at least one drug that was potentially inappropriate given their age and health status, and that the majority of these cases had not been flagged in any recent medical review. Regular medication reviews, ideally at least annually and more frequently for those on multiple medications, are not optional for seniors. They are essential, and yet they remain far less routine than they should be. The question is not whether to trust your doctor. The question is whether your doctor has had the opportunity to review your full medication picture recently with your current age and health status in mind. If the answer is no, that conversation is overdue. The second pill is one that many seniors take for sleep, anxiety, or muscle tension, and which we have touched on in other contexts. Benzodiazepines. Medications like diazepam, lorazepam, temazepam, and alprazolam are prescribed for real and legitimate reasons, and they can be genuinely effective, particularly in the short term. But from a cardiovascular perspective, the risks of long-term benzodiazepine use in older adults extend beyond the cognitive and balance concerns most people associate with this class of medication. These drugs affect the central nervous system in ways that can influence heart rhythm, blood pressure regulation, and breathing during sleep. In older adults with any degree of sleep apnea, which often goes undiagnosed, benzodiazepines can worsen nighttime oxygen levels in ways that place additional stress on the heart. There is also evidence linking long-term benzodiazepine use in seniors with an increased risk of falls leading to serious injury, and with subtle but measurable changes in cardiovascular markers over time. The monitoring strategy your doctor should be applying if you are on a benzodiazepine includes regular reassessment of whether the original indication still exists, whether the dose remains appropriate, whether alternatives have been discussed, and whether any symptoms, including morning grogginess, balance changes, or increased blood pressure variability, might be connected to the medication. If these conversations have not happened recently, initiate them. Let me share one more story. Robert Fitzgerald is 68 years old, a retired firefighter from a city in the west of Ireland, a man who spent his career taking care of other people in crisis, and who, as a result, found it genuinely difficult to ask for help himself. Robert had been taking a combination of medications for several years, a beta blocker for blood pressure, a statin for cholesterol, and a sleeping tablet that he had been prescribed after a stressful period about 4 years earlier. What Robert had been experiencing was a combination of symptoms he dismissed as just being tired and getting older. He felt sluggish most mornings. His resting heart rate felt strange to him occasionally. Not fast, but irregular in a way he could not quite describe. He had gained some weight without changing his diet significantly. And his blood pressure, despite the medication, seemed inconsistent when he measured it at home. When Robert's new cardiologist reviewed everything, several things became apparent. The benzodiazepine he was taking for sleep was interacting mildly with his beta blocker in ways that were contributing to his morning sluggishness and some of the blood pressure variability. His sleeping tablet was also worsening mild sleep apnea that had never been formally diagnosed. Under supervision, the sleeping medication was gradually tapered and eliminated over 3 months, with sleep hygiene strategies introduced in its place. A sleep study confirmed and addressed the apnea. 6 months later, Robert's morning heart rate was steadier. His blood pressure was more consistently controlled. He had lost 4 kilograms without any dietary change, which his cardiologist attributed in part to the improvement in sleep quality. And his energy, which had been declining for 2 years, came back in a way that genuinely surprised him. Robert said, with characteristic understatement, "I thought feeling that way was just what getting older meant. Turns out, some of it was what the tablet was doing to me." Here is your practical medication safety checklist, because knowledge only protects you if you act on it. Start by writing down every single medication and supplement you currently take. Include the name, the dose, the frequency, and how long you have been taking it. This list should include everything: prescription medications, over-the-counter drugs, vitamins, herbal supplements, and anything else you take regularly. Bring this list to every medical appointment. Request a formal medication review at least once a year, not a casual mention at the end of a routine appointment, but a dedicated review in which your doctor goes through every item on that list and asks whether it is still necessary, whether the dose is still appropriate, and whether there are any interactions between your medications that deserve attention. If your practice offers pharmacist-led medication reviews, these can be extremely thorough and are worth requesting. Keep a symptom diary for 2 to 4 weeks. Note any episodes of dizziness, chest discomfort, unusual fatigue, irregular heartbeat, swelling in the ankles, unexplained shortness of breath, or changes in your sleep quality. Specific dated information gives your doctor something concrete to work with rather than a vague sense that something feels off. Know what questions to ask. At your next appointment, ask whether any of your medications appear on senior safety watch lists, such as the Beers criteria. Ask whether your kidney and liver function has been tested recently and whether your medication doses account for any changes. Ask whether there are non-medication alternatives for any of your current prescriptions. Ask whether any of your medications could be affecting your blood pressure, heart rate, or sleep quality. Know the symptoms that require urgent attention, not a scheduled appointment. Chest pain or pressure, sudden shortness of breath, an irregular or racing heartbeat that is new or worsening, sudden dizziness or a feeling of nearly fainting, sudden weakness or numbness on one side of the body. These are symptoms that require emergency medical attention, not a note to mention at your next checkup. And remember, never stop any prescription medication on your own based on something you have read or watched. The information in this video is designed to help you have a better conversation with your doctor, not to replace that conversation. Tell me in the comments how many prescription medications you currently take. You may be surprised how many people watching this share a similar picture and how many are having the same concerns you are. Now let's talk about pill number 1, the medication that surprises most people when it appears on a senior cardiovascular risk list. That medication is a type of drug that many older adults have been told is heart protective, commonly prescribed, and about as mainstream as anything in modern medicine. Certain hormone-based medications, and more specifically, some formulations of hormone replacement therapy and hormonal treatments used beyond their intended short-term duration. This is a nuanced area, and it deserves to be addressed carefully and without sensationalism. Hormone therapies, including estrogen-based treatments sometimes prescribed for menopausal symptoms, and testosterone treatments increasingly prescribed for age-related hormonal decline in men, have genuine benefits in the right context, at the right time, for the right patient. Nobody is disputing that. But here is where the concern lies. Research published in the Women's Health Initiative, one of the largest clinical trials ever conducted in women's health, found that certain formulations of combined hormone replacement therapy, estrogen combined with progestin, taken by postmenopausal women, were associated with a modestly increased risk of heart attack, stroke, and blood clots in women over 60 who started therapy a decade or more after menopause. The timing of initiation, the formulation used, the duration of use, and the individual patient's cardiovascular risk profile all significantly affect this calculation. But the key finding that many patients have never been clearly told is this: hormone therapy that was appropriate to begin at 51 may carry a different risk profile if it is continued without review into the late 60s or 70s. On the male side, testosterone therapy, increasingly prescribed for fatigue, reduced libido, and age-related hormonal decline, has been the subject of ongoing cardiovascular research, some of which has raised concerns about increased risk of cardiovascular events in older men with existing heart disease or high cardiovascular risk. The FDA has required label updates reflecting these concerns. Clinical societies have issued guidance recommending careful patient selection and ongoing monitoring. The reason this pill lands at number 1 is not because hormone therapy is universally dangerous. It is not. It is because it sits in a category of medications where the risk-benefit calculation changes significantly depending on when treatment was started, how long it has been continued, and whether that calculation has ever been formally revisited in the context of a patient's current age and cardiovascular health. If you are taking any form of hormone therapy and you have not had a specific conversation with your doctor about whether it remains appropriate at your current age with your current cardiovascular risk factors, that conversation is overdue. Ask about the evidence. Ask about the risks specific to your health profile. Ask whether continuing makes sense and for how long. Protecting your heart and brain after 60 is not only about medication management, it is about the daily choices that support your cardiovascular system alongside whatever medical treatment you are receiving. Begin your morning with hydration. A glass of water before anything else, before coffee, before breakfast, helps your kidneys begin the day well and supports healthy blood pressure regulation from the moment you wake. Your breakfast should include protein, which stabilizes blood sugar and reduces the cardiovascular stress of a glucose spike in the morning. Eggs, Greek yogurt, smoked fish, or a small portion of cheese with whole grain bread are all good choices. Avoid starting the day with sugary cereals or white toast alone. Physical movement in the morning, even gentle movement, is one of the most powerful cardiovascular protective habits available to you. A 20 to 30-minute walk after breakfast at a comfortable pace improves circulation, supports blood pressure management, and signals to your cardiovascular system that it is being used and maintained. You do not need a gym. You need consistency. Through the day, aim for adequate hydration, 6 to 8 glasses of water, and try to eat your meals at regular times. Blood sugar stability has a direct effect on cardiovascular stress, and erratic meal timing contributes to the kind of metabolic fluctuation that places strain on the heart. In the evening, manage your stress deliberately. Chronic low-level stress is one of the most underrated cardiovascular risk factors in older adults. A short period of quiet, reading, gentle music, a relaxation practice, a conversation with someone you care about is not indulgence. It is cardiovascular medicine. Cortisol, the stress hormone, raises blood pressure and promotes inflammation, and anything that reduces it consistently is protecting your heart. Go to bed at a consistent time, in a cool room, with minimal light and screen exposure in the hour before sleep. Good sleep is not separate from heart health. It is central to it. Before we close, this must be said clearly and with full sincerity. Nothing in this video is a reason to open your medicine cabinet tonight and stop taking what is in it. Not a single pill discussed here should be discontinued, reduced, or replaced based on anything you have watched today. Stopping medications suddenly, particularly blood pressure medications, heart medications, benzodiazepines, and certain hormone therapies, can cause serious and, in some cases, dangerous rebound effects. Blood pressure can spike, heart rhythm can become unstable, withdrawal symptoms can be severe. The risks of stopping without medical supervision often far exceed the risks of continuing while a proper review is arranged. What this video is, and this is important, is a preparation tool. It is the information that helps you walk into your next doctor's appointment with better questions, more awareness, and a clearer sense of what deserves a second look. Every medication discussed here has legitimate uses. Every concern raised here has a responsible, medically supervised pathway to address it. Talk to your personal doctor before making any medication changes. Not a neighbor, not an online forum, not a family member who has strong opinions about pharmaceuticals. Your personal doctor, who knows your complete history. That conversation, informed by what you have learned today, is exactly the right next step. The goal of everything you have just heard is not to make you afraid of your medication. Fear is not useful here. What is useful is awareness, curiosity, and the willingness to ask better questions.